much would you give me now to just go and have pizza?
A lot.
A lot. So, good luck.
Thank you. So, thanks to Eric and Monica for inviting me to take part in this really exciting and I think fun evening. Maybe not thanks so much for giving me a really challenging task to particularly go up against Martin, who is extremely knowledgeable. I think it's going to be even more difficult now for me after the data that Martin has shown you to convince you to not hold up the wrong sign. But I'll try to shine a light from a different angle, from multiple different angles on this question, to just get you thinking a little bit and cast shadows of doubt on the argument for chronic treatment. So where I would like to start is the subgroup analysis, because we're still talking about this as if this is something that will apply to all myeloma patients. Clearly it's not. So this is from a paper on autologous transplant patients and maintenance therapy in myeloma, an Italian study. Patients randomized to induction with 4 cycles of RD and then randomized to a tandem transplant or 6 times MPR, and then they were randomized again to no maintenance versus maintenance. And I think it's pretty obvious, as you can see here, in terms of progression-free survival, the transplant arm with maintenance is much better than the transplant arm without maintenance in terms of progression-free survival, which is actually about the same as MPR with maintenance, and the worst is MPR without maintenance. So this is actually in favor of Martin's argument. But actually, could we take a look at the 5-year overall survival curves, please? Because they're always much less impressive, and even quite far down the line, they're pretty close together. If we look at from start of maintenance in terms of progression-free survival, this is, again, very impressive. If you look at this, it's obvious that you should give maintenance because the progression-free survival is so much further up than with maintenance than without. But let's look at overall survival, which is, after all, still something important to consider. And there is no difference. It's the same. Doesn't matter whether you give maintenance or not. So if we go into details of this and look at the benefit of treatment arms for subgroups, I'd like to start with the benefit of high-dose melphalan with an autologous stem cell transplant, the quintessential non-chronic treatment. It's a one-off, in this case, double hit with something really nasty and toxic, but it really works. High-dose melphalan benefits, in terms of progression-free survival, all subgroups that you can look at. Let's do the same with maintenance therapy, and it becomes clear that that's not the case anymore, even for progression-free survival. ISS 3, no benefit. Patients with complete response, no statistically significant benefit. Funny enough, those with stable disease, which are bad, also no statistically significant benefit. Yes, this dot is on this side of the line, but if we're accepting the value of a p-value, then we have to consider this. And if we look at cytogenetic risk, high risk, no benefit of maintenance. And if we then look at the subgroup analysis for maintenance for overall survival, this comes out, there's no benefit for anybody. So let's look at the first trial again. Martin has talked about this. Very large trial. Just to repeat very quickly, MPT for 72 weeks versus Lendex for 72 weeks versus Lendex continued until progression of the myeloma. And this is the curve that Martin has pointed out, the progression-free survival curve. Obviously extremely impressive, but let's look at overall survival. They're pretty close together, these lines. And yes, in terms of the hazard ratio, continuous Lendex is significantly better than MPT, but it's not a huge difference. And if you compare continuous Lendex with Lendex 18, it's not statistically different. And finally, another New England Journal of Medicine, continuous lenalidomide for newly diagnosed multiple myeloma, the MM015 study in patients 65 or above. MP times 9 versus MPR times 9 versus MPR times 9 plus Revlimid maintenance. And again, a wonderfully impressive progression-free survival curve, which clearly shows that maintenance is highly superior. But let's look at the overall survival curve, and it actually goes out quite a bit. This is sort of coming up to 4 years here. There is no statistically significant difference between not just MPRR and MPR, but even between MPRR and MP. Right, and again, if we take a closer look at the subgroups, the older patients over 75 in this case don't benefit. So now that we've dealt with PFS versus overall survival, I'd like to look at a few other issues. One is adherence. How adherent are patients going to be to real-life treatment? Because obviously patients in trials are going to be much more adherent than your normal myeloma patients walking into your Tuesday morning clinic. And would poor adherence possibly affect outcomes? Now, we don't really know much about adherence in myeloma, I think. This is a relatively small but British study. UK myeloma patients on CTD, 64 patients. 92% of them reported that they were fully adherent to the treatment. But a third of them relied on their partner or family member for help with the medication. And over half, only just over half, knew when to take their medication. Do we really think they were 90% adherent? Probably not. And this is just from a different disease, CML. This is a study coming out from my CML colleagues at the Hammersmith, where they looked at adherence in CML patients treated with imatinib. So that's younger patients, healthier patients, probably more able to take their drugs and be in control of their treatment, and they're taking a very generally nicely tolerated simple pill, one. And what they showed is, first of all, that over 1 in 4 patients had an adherence of 90% or less to the treatment. Now you would say, well, missing one tablet out of 10, does that make a difference? It makes a huge difference, at least in CML, because those that had an adherence of 90% or more had a 90% probability of reaching a major molecular response, whereas those that had a 90% or less adherence had only a 15% probability of reaching a major molecular response. So it's quite likely, or at least very possible, that something similar would happen in myeloma. But we probably have to find out. And it's not just the actual drugs, the anti-myeloma drugs, it's also supportive care, anticoagulants. Just last week, I had a patient of mine, very switched on lady in her early 70s, on Revlimid, dexamethasone, cycle 4, and for about a week, she forgot to take her low molecular weight heparin, comes in with a major PAE. Right? This is a problem. Toxicities, well, we all know the toxicities of the various drugs we're giving, but I just wanted to, a little food for thought. This is a study from the Lancet Hematology from last year, financial toxicity in insured patients with multiple myeloma. This is a US study. Yes, the US are different. A survey of individuals receiving at least 3 months of ongoing treatment at the tertiary academic medical center in the US. And with all the differences between the US system and our system, we do have younger patients that go to work. They still need to create an income. Some of them are self-employed. So it is an important issue for at least some of them. And if you look at this, then you can see that more than 2/3 of the patients reported a minor to significant financial burden. And that led to decreased spending on basic goods like food, clothing, or leisure activities in more than half of the patients. But at the same time, most of the patients were not very likely to discuss this issue with their oncologists. Now, the NHS situation is probably much better, but we need to at least think about that. One more toxicity issue, the second primary malignancies question. That's a very long story. And that's exactly the point of the slide, not necessarily exactly what sort of lenalidomide combination probably or not leads to higher rates of second primary malignancies. It's the point that for years we've been trying to figure out if there is a higher rate of secondary cancers and what exactly causes that. And that creates cost, effort, and anxiety. And again, that just means that the complexity of long-term toxicities in relation to concomitant previous therapies is something we need to really bear in mind. And this is a poster, I think, presented at EHAR several years ago, which was nicely sent by the Myeloma UK team. It was a study by Myeloma UK, a postal survey of 600 myeloma patients in the UK, looking at 3 quality of life measures, and that, at least in that time period, showed that being in a treatment-free interval was associated with better health-related quality of life, and I think most patients would agree that they prefer to be off treatment. There are some that like to be on treatment because it gives them a sense of security, but most patients probably want to be off treatment. Right, clonal evolution. I'm already coming towards the end of my argument. We've heard about clonal evolution from both previous speakers, so it's obviously an important issue. And for me, it's really fascinating and the area where the big advances in myeloma will come from. But could maintenance, intermittent therapy, however you call it, alter myeloma cell biology and thus responses to treatment later on? And in that respect, we have to consider that the PFS after the first line of treatment might not be the only ultimate outcome we have to look at. And there are many papers now coming out, and this is just a almost random selection of blood papers from this year, where it was shown that treatment does affect clonal evolution a lot in terms of the combination of BRAF with NRAS mutations, KRAS, NRAS, and P53 mutations, but also that treatment with lenalidomide can cause cereblon mutations, and that will make patients unresponsive to IMiDs. And if we think about that, then we have to consider that possibly we need to learn more about how many patients are affected by this, what really the details are in terms of how does maintenance or chronic therapy early in the disease course affect later responses to drugs. Because if those patients have a very nice long PFS1, but then they have a cereblon mutation and the P53 and the KRAS, then they won't do very well later on. So what are the many things to consider? The direct drug costs, patient preference, impact on daycare units with indirect costs. There are geographically remote areas where monitoring may not be as easy as it is in London. Unexpected long-term toxicities, the real-life benefit outside of studies. And therefore, I come up with this sort of personal opinion stained by blotches of evidence here and there, that yes, it's clear that maintenance with lenalidomide can benefit patients, but we don't really know which patients, after what treatment, and particularly treatment line, because I think all the relevant studies are first line. So what do we do in second line, third line? What do we do in the current situation where we use Revlimid mostly third line? Is maintenance of any benefit in that stage of a disease? And yes, maintenance will almost certainly play a role in improving myeloma outcomes, but we really need to figure out how to do it without harming patients and the NHS. And then also bring up this word here, biomarkers. I actually don't like the word because it's such a vague thing that is often abused for various purposes, but we need biomarkers. We need really to find out for the individual patient whether we should give them maintenance or chronic treatment or not. And I really liked Rafat's formula that he showed, but that is one formula. It may work for some patients, but probably other patients don't need that. And we will have patients where we need to have very intensive therapy, but we also have these patients that somehow almost magically have fantastic responses. And usually they're the ones that have had a stem cell transplant. But last week I saw a patient who I inherited from one of my colleagues who had 4 cycles of ZX in 2005 and is still in complete remission. And I looked up the history because I thought that was probably not the right diagnosis. No, it was. It was proper myeloma with all the complications. So we just need to learn more about the details of the biology of the individual patient, and I think then we don't even need many more new drugs. Thank you very much.